statewide webinar, What's the Latest? Thank you all for taking the time to join us today. I know people have busy schedules, and we're excited to have a group of experts here today to share their experiences around hepatitis C. So for those who may not be aware, May is Viral Hepatitis Awareness Month. And so we decided for today's webinar to focus on the topic of hepatitis C in Washington State and hepatitis C treatment specifically amongst the patients that we provide care for. So in order to allow plenty of time for our presentation and panel discussion, I'm gonna get us started. To begin, this is a Zoom recording. We will be recording this and sharing it on our website. Please mute when you're not speaking. Feel free to put questions in the chat. And if you have any concerns about technology, reach out via chat and folks from our team can help you out. And this is our agenda for today. We're going to start with a land acknowledgement and then move into the discussion, Navigating Hepatitis C Care, Insights from Washington State. Jonathan Stockton from the Department of Health is here today to share sort of a high-level overview of what's going on in the state of Washington. And then we have some panelists from Harborview Medical Center, Evergreen Treatment Services, and PCHS on the Peninsula to talk to us about how these programs have incorporated hepatitis C treatment into their primary care work. And we'll wrap up with some questions and discussion at the end. So I'd like to begin by acknowledging that as we gather here today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest gratitude and respect for our indigenous neighbors. And now I'm going to hand it over to Jonathan Stockton to tell us about what's going on in the state of Washington.
Great. Thanks so much, Marie. And thanks so much, everybody, for having me. My name is John Stockton. I am the Adult Viral Hepatitis Prevention Coordinator here in the Office of Infectious Disease here at Washington State Department of Health. So I have a short time with everybody, so I'm going to be providing a pretty high-level overview of the burden of hepatitis C infection within our state, talk briefly about the Hep C-free Washington initiative, and then talk a little bit about some of the high-impact priorities that we are focusing most of our efforts on here at the state. Next slide. So the first thing I want to go over is just a bit about what we're seeing here in Washington State. So hepatitis C became a mandated reportable condition in 2000, meaning that laboratories, healthcare providers, and healthcare facilities need to, by law, report hepatitis C cases to their local health jurisdiction, which then makes its way to the state. So we have a lot of limitations with our surveillance, unfortunately. Even though we do have, it is mandated that we receive those case reports, oftentimes we do not. What we do receive is most of the time laboratory reports, which don't have a lot of information on them. So we're unable to actually see things like race and ethnicity and also potential exposure in our cases. So much of our data is missing, unfortunately, because we don't receive those case reports from providers. However, in saying that, you'll see throughout my presentation when it comes to any kind of epi data that there are some things missing, but I will do my best to answer any questions that arise. So as you can see on the right-hand side, from 2012 to about 2017, we saw a noticeable increase in the number of cases that were reported to the state. In 2017, we saw our highest number of chronic reported cases of 8,865. Then heading into 2018 and 2019, as we all know, the pandemic really did decrease individuals' ability to go see healthcare providers. And so as a result, we saw the number of cases overall drop pretty significantly. And this was not unique to just hepatitis C. We saw drops in HIV cases and also STI cases as well. Heading into 2021, as you can see, we have 3,998 reported cases of hepatitis C. In 2022, we saw about 8 less cases. So again, about 3,990. Preliminary data for 2023, we saw another significant drop in about 1,200 cases to 2,758 cases. So again, we continue to see that decline in the number of cases that have been reported to the state. One of the questions that a lot of folks have when going over hepatitis C data is just how many individuals in Washington state are actually living with hepatitis C. So, what does the burden look like? And unfortunately, that's a really tough number to get. So, we're talking about prevalence, and it's really difficult to do based on our limitations of the data. We're not able to accurately track the number of individuals that move out of the state, those who have been cured, or those who have passed away. We did take part in a study from the Center for Disease Analysis back in 2018 when we were doing our Hep C-free Washington planning. And we took part in this study, which did some modeling for us. And working with CDA, they used some very large data sets, such as Medicaid data, claims data, our own surveillance registry, and some of the larger surveillance registries from some of the larger local health jurisdictions. And what they were able to see and what they were able to do through their modeling techniques is find that we have roughly about 59,000 individuals right now in Washington state impacted by hepatitis C. Now, you got to take that number with a bit of a grain of salt because, as you can see there, the ranges anywhere from 32,000 to 71,000. So, after much discussion, 59,000 is what we ultimately landed on. Next slide. So case rates. So when taking a look at rates, what's really unique to hepatitis C is that unlike other conditions within our office like HIV and STIs, is that it doesn't necessarily follow population density when you take a look at just rates. Hepatitis C is vastly different in that it disproportionately impacts our more rural communities, which, as you can imagine, really does present some unique complexities to how we actually plan and implement and deliver services within these areas. Because these areas don't have as many resources, it does pose some really unique challenges in mostly trying to find providers who are willing to treat hepatitis C in some of these more rural areas. But again, hepatitis C is found in every county within Washington state and particularly disproportionately impacts some of our more rural communities. Next slide. So this is the care continuum that again was developed by CDA analysis. We were one of 4 states that took part in this study. And what you can see here is that the red bar represents the number of individuals in Washington that we believe are impacted by hepatitis C. The light colored blue bar represents the amount of individuals that we believe already know their status or who have been tested and RNA positive. And that ranges about 88% of the overall number of 59,000. And then, as you can see, things kind of go wrong, which is we see a significant drop off in the number of individuals who know their status who actually initiate care. So, of the 88% of the individuals that we believe already know their status, only roughly about 12% of those individuals actually initiate care. Those folks that do initiate care and complete care and treatment, 95% of those are actually cured. So as you can see, that significant drop off in the care continuum is really where we focus much of our efforts, which is getting people linked into care and supportive services, which is one of the toughest jobs that we really are faced with right now. Is how do we navigate somebody from point A to point B? It's very difficult to do, and I'll talk a little bit about that here as we go along. Next slide. So as you can imagine, there's been significant advances in hepatitis C work. Most notably, we have a cure now, and a very effective cure of around 95%, with very good direct acting antivirals that can cure an individual in little as 8 to 12 weeks with minimal side effects. For those who have been in hepatitis C space for some time, this is much different than the old treatment regimens of interferon and ribavirin treatments, which had significant side effects for those individuals that took part of those really old um, treatment regimens. Because when these did hit the market, the new medications are really started to propose some questions, not only here in Washington state, but across the nation and also at the World Health Organization, is that with these new medications, is elimination possible? And because those discussions started happening, the governor's office started asking us what would it take to eliminate hepatitis C in Washington state. So a very small work group formed in spring of 2018, and that was made up of some members from Healthcare Authority, our state Medicaid program, the prison system, and members from the Department of Health. And from that small work group, we issued a paper, which then went to the governor's office and Governor Jay Inslee, the first ever in nation health directive to eliminate hepatitis C in Washington state by the year 2030. Now, within that directive, there's a lot of directives in there. There's two very important ones that were actually directed towards two organizations. The first directive was for the Department of Health to convene a multi-sectoral work group and to develop a comprehensive elimination strategy for Washington state. The second was for Healthcare Authority, our state Medicaid program, to develop an innovative pharmacy procurement strategy to lower the cost of drugs. Next slide. So the first thing that happened in 2018, it took us about 10 months of actual planning to develop the comprehensive strategy. Is that really when the meds did hit the market, the big headline wasn't we have a cure for Hep C now. The big headline was that the Hep C drugs now can cure hepatitis C, but it's going to cost $90,000. As you can imagine, that raised a lot of eyebrows when that first hit the market. And in response to this, many states across the nation put in some really restrictive policies for the payment of these medications, and Washington was the same way. Which is the prior authorization process, which has some really restrictive policies in there, such as individuals had to be clean and sober for X amount of years. Only specialists could actually treat hepatitis C before those medications were approved for payment. During our planning process, Healthcare Authority decided to lift some of those restrictive policies so it could help the Hep C-free Washington initiative. And so the new policies aligns with national experts in AASLD and IDSA guidance, which is there's no longer sobriety requirements. Evidence of fibrosis is not required. Any licensed provider is allowed to screen and treat. And this was a real big one because prior to this, only hepatologists and gastroenterologists were able to actually prescribe and treat. Wait time to validate chronic conditions were not required, and prior authorization is not required for AbbVie's Maverick product. In July of 2019, Healthcare Authority, in response to the directive, issued an RFP. AbbVie was the successful bidder, and so we have a modified subscription model now within our state to lower these costs of drugs. So once we hit a certain threshold of individuals who have been treated with this product, then the cost of those drugs becomes pennies, becomes essentially free. Next slide. So the other part of the directive was to develop a comprehensive strategy, which was done. It took about 10 months of planning. We had a multi-sectoral work group that we helped to lead through collective impact was the model that we used. We had members from all over the state. We had lots of pharmacies. We had quite a few providers. We had CBOs or community-based organizations, members from certain service programs. The VA was also there, and also quite a number of individuals from academic institutions. And so we were able to put together those recommendations, and we released the comprehensive elimination strategy for Washington State in July of 2019. The plan is comprised, it's pretty light reading. It's only 15 goals and over 90 recommendations, which if you're thinking, well, that's a lot of recommendations, and it is. I think that points to just how much needs to be done in order to eliminate hepatitis C in Washington. Next slide. So I'm not going to go over, of course, all the recommendations. I don't have that time, but I'm going to highlight one of the recommendations. And one of the big recommendations is to expand the provision of clinical services, including Hep C and other infectious disease screening and diagnostic testing, linkage to care services, Hep C treatment and vaccination, wound care, overdose education, and naloxone distribution in high impact settings. So high impact settings represent certain service program, OTP and MOUD, and also folks that are incarcerated. So the prison system and also local county jail health. when taking a look at our data, we do know again that even though it is limited, disproportionately hepatitis C impacts those individuals who use drugs, and also, thinking about where we best meet those individuals and how we can touch and provide those services. So high impact settings has been a real big priority setting for us, particularly with SSPs and most notably OTPs. So some things that we have done up to this point is in collaboration with the University of Washington and the Washington State Opioid Treatment Authority and Healthcare Authority, we developed a statewide OTP and MOUD infectious disease assessment survey. We did this with all the OTP sites in Washington State. It was a couple of surveys. One was specifically tailored for the medical directors, and the other was for the site directors. And we wanted to know exactly what was going on and what kind of services, if there's any physical, actual services that were provided within these sites, particularly around infectious disease. So not only HIV and STI, but most notably hepatitis C. So what was going on? And what we got back really varied across the state. We did find some sites that did provide screening and also treatment on site. We found some sites that were providing screening, but were maybe referring out for medical care for hepatitis C or other infectious diseases, and some that weren't really actually doing anything. And that really had a lot to do with the capacity of those sites to actually deliver those services. We found a lot of barriers too. One of the biggest ones is for the individuals that were currently providing, or these organizations that were providing, so let's say hepatitis C services with an OTP setting, or who had contemplated it. One of the biggest barriers was just the low reimbursement rates for those services provided. So it was definitely a money losing situation. The other was really just a lack of awareness around hepatitis C and how that impacted the individuals that were coming into those sites. And so, in response to that, we did quite a bit of work around this. We still continued ongoing collaboration with OTP providers, clinical and administrative leadership, really continuing to talk about hepatitis C, the importance of having these services delivered in under one roof for the individuals they see, and then really wanting to take a look at Washington Administrative Code 246-341, which governs all behavioral health agencies, and thinking about how we could integrate infectious disease screening within that WAC. And we still continue to support screening and linkage to care services within our service program in Washington State. We have a very mature SSP model within our state. We're one of the very first models to actually provide public funding for certain service programs throughout the state. And then also something that's new is the Medication Transformation Project, or the 1115 waiver that's headed up by the Healthcare Authority, which is the Reentry Demonstration Initiative, which is actually really pretty amazing. When folks enter into jail or prison, some of you may not know or know that if an individual has insurance, especially Medicaid, that Medicaid is turned off. They are no longer covered under Medicaid. This demonstration waiver actually is going to go through. It's going to start next year, which I'm pretty excited about, which is individuals are able to receive services while they're in jail 90 days prior to release. One of those things that's specifically highlighted within that waiver is the provision of hepatitis C testing and also treatment. So it's pretty remarkable. I'm actually really excited to see that. So there is some steps happening there. Next slide. So, what makes Hep C elimination possible in Washington State? I'm not going to read all these for you, but I'm going to highlight a few of them. One is that we do have drug user health infrastructure within our state, including access to certain service programs and medication treatment for opioid use. We do have committed medical providers willing to treat hepatitis C. We need more of them, but we have some real leaders within our state, most notably within the University of Washington. Um, Academic institutions with clinicians and educators studying Hep C interventions and building provider capacity. Our state, of course, is Medicaid expansion. Also, we are improving Hep C surveillance and assessment efforts and CSC support for some Hep C programming and surveillance, but it is lacking. Hepatitis C is one of the least funded conditions within our office. One important thing that I forgot to note is with that Governor Jay Inslee's directive, there was no money that was attached to that. So most of all that work and the work that we continue to do is really with the same budget. So there was no new money that actually came to our office for that effort. Next slide. So for some potential barriers, of course, increased homelessness and displacement for especially their priority populations that we're most concerned with. Increasing incidence of Hep C among young people who inject drugs. When you take a look at the age cohorts for those impacted by hepatitis C, we have seen a noticeable shift in demographics with age. We're seeing much more young people contract hepatitis C. More than ever. Primarily, it impacts two groups of individuals, the baby boomer age population and now younger individuals. Those born after 1992 is actually one of our priority populations for our disease investigation specialists who actually outreach to these individuals to provide risk reduction counseling and do our best to link them into care and supportive services. So the reason for that is absolutely the overlap of the opioid epidemic that we're currently experiencing. Limited federal investments, already touched upon that. Very little funding for hepatitis C, unfortunately. But we do receive federal funds, like most states do. We receive about 150,000 a year to eliminate hepatitis C. For our state, which, as you can imagine, isn't a lot of money. That pays for one FTE and keeps the lights on, more or less. We are one of the rare states that do receive some state funding for hepatitis C, so we are lucky in that regard. But again, not nearly enough to actually develop a comprehensive, responsive model to what we're currently seeing. Next slide. Okay, hopefully I kept that in 10 minutes. There's our contact information. We have the Hep C-free Washington delivery system there. And also from the Healthcare Authority, they also have their own contact information as well.
Thank you so much. Thank you, John. That was excellent. And if people have questions for John, please feel free to put them in the chat. We'll save questions till the end. We're going to move into our next portion of the webinar, which is a panel discussion with Dr. Jocelyn James, who is coming to us from Seattle Harborview Medical Center and the Evergreen Treatment Services, which is an OTP, and Albert Carbro and Hannah Erickson. Albert is a pharmacist and Hannah is a physician's assistant. They work with the Peninsula Community Health Services, which is a FQHC in Kitsap, Mason, and Pierce County. So they have more experience on the rural side, and then Dr. James will be able to speak more to the urban side. And I'm going to unshare my screen, and I'll invite Dr. James if you want to unmute and just introduce yourself and tell us a little bit about the kind of setting that you work in and any nuances about that you think are relevant for folks to understand.
All right. Thank you so much, Maureen, and thanks for having me. I did want to clarify, do you want me to go into some of the Hep C treatment, like what that looks like, or do you want me to just give an introduction to the settings I'm working in?
Just an introduction for now, and then we'll move into that next.
Okay, sounds good. Yeah. So again, my name is Jocelyn James. I'm an assistant professor here at the University of Washington, and I work primarily, my clinical work is based at Harborview Medical Center. And I do primary care and addiction medicine here. We have a satellite clinic. One of our large primary care clinics here at Harborview has a satellite clinic that's located at an opioid treatment program nearby, Evergreen Treatment Services. And I've been doing primary care there, on site there, since early 2016, and have been the associate medical director there for the last couple years. So I do patient care, direct patient care. I help some with administration at the satellite clinic that I just mentioned. I do a fair amount of teaching with residents and addiction medicine fellows. And then I've had the opportunity to work with John and Emily Hurriot to some extent in some work that I could describe later, but around hepatitis C training, especially training kind of targeting treatment, trying to expand treatment among people who provide opioid use disorder care.
Thank you, Jocelyn. Albert, do you want to unmute yourself and just let us know a little bit about where you're coming from?
Yeah, so I'm a pharmacist that has had the pleasure of working with Peninsula Community Health Services, again, a federally qualified health center here in semi-rural, working with the opioid use disorder program here, but just more broadly trying to help with policies and procedures that kind of help us provide some equity across the board.
Thank you. And Hannah, if you want to introduce yourself, and then we'll move into the discussion.
Yeah, so not much to add on to what Albert said, but I'm one of the primary care PAs here, so in the implementing of our Hep C program.
Thank you all. So to get started, like to hear, and Jocelyn, I'll go back to you, just hear a little bit about the pathways to hepatitis C treatment in the two settings that you work in, and any other settings that you're sort of involved in that work.
Yeah, sure. So there are a few, I have a few settings I'd like to describe. So I guess the first one really is this main primary care clinic that I've been working in since 2012. And I should have mentioned, but one thing that helped me get involved with this that was fortunate opportunity, because I was always interested in hepatitis C treatment and in liver disease, was I got to spend some time with our hepatologist in 2015 and got to work for 6 months in liver clinic. And after that, the idea of that was that I and another provider would go back to our primary care clinics and do treatment there in primary care. So I just really appreciate that there was some recognition early on with DAAs that we need to be treating people in primary care. Not everyone needs to go see a specialist. So when I, after that experience, basically I kind of took charge of trying to recruit residents in our clinic to do hepatitis C treatment, and I taught residents how to do Hep C treatment. We essentially had a group of residents who opted into that, and we had a handful of providers who were treating, and we relied very heavily on our pharmacists. I'm so glad that you're here, Albert, but we had a couple pharmacists in our primary care clinic who were really instrumental to getting that off the ground, and also just really to maintaining and sustaining it over time in this setting where we have 60 providers, a lot of trainees who come and go over time. So the pharmacists have been just continue to be really, really key to that. But as I was mentioning to Maureen earlier, we went from a model several years ago of having interested residents opt in, and we were doing more intensive training, case discussions, journal club, et cetera, to in the more recent couple years, really just doing some basic education periodically, and trying to really get the word out that this is something that everyone in our clinic should be doing, attendings and residents alike. And if you don't feel comfortable, you don't really know how to get started, we have a lot of resources here. We are really spoiled in that, both in the pharmacists and then also, providers who've been doing this for a while. And of course, it's very easy for us to refer to specialty care. So, so we've been doing hepatitis C treatment in our clinic, and then the satellite clinic around the same time, we started doing hepatitis C treatment there as well. And so again, this is located at an opioid treatment program at Evergreen Treatment Services. And by far the most common reason for referral, other than just somebody wanting primary care in general, is hepatitis C treatment. It was very much the case, and it probably still is the case, but that's a really common reason for referral to our clinic there. And so we were working with a pharmacy, actually not with Harborview, but with a couple community pharmacies to do hepatitis C treatment there. Maureen kind of asked about numbers. I looked at our spreadsheet for the primary care clinic, the home primary care clinic. It looks like we've treated in the last just over 2 years, we've treated 25 people. So it's not huge numbers, but I think definitely impactful. And I don't have up-to-date numbers from the satellite clinic, but we did, some colleagues and I did look at this back in a few years ago and did a retrospective analysis and found we had treated 50 patients between those two settings. and with really high rates of cure. So in the, roughly like 90% range of cure, and that included people who were on buprenorphine, people who were on methadone, and people who were on neither. I guess I'll just briefly mention another. I recently had the opportunity to get involved in a collaboration with Kelly Ross Pharmacy. It's a collaborative drug agreement model essentially. And so a couple colleagues and I are on a CDA, collaborative drug agreement with several Kelly Ross pharmacists, and the pharmacists are essentially offering not only hepatitis C treatment, but a number of important other, infectious disease screening and treatment, et cetera, sort of syndemic conditions. And so I'm fairly newly involved in that, but it's been a really successful program as well, and helped to support treatment at the OTP. And then finally, just one other quick introduction to, if there's time or interest, we could come back to this, but I've worked with with Maureen and another colleague in our clinic, specifically trying to improve Hep C treatment among people who are in our OBOT program. And so we've rolled out just more consistent screening and of people in our program, and also rescreening for people with risk factors. And so that's a key part, because we were not we weren't screening enough prior to that. And then we've basically, we're piloting or have recently started a nurse-led treatment program where our buprenorphine nurses, our OBOT nurses, are really getting everything started. They're starting with the first visit and having discussion about screening. They're getting the process started, identifying what else needs to be done, helping pen lab orders, et cetera. And the idea of that really is to expand treatment access and also just really speed it up and try to remove some of those delays and barriers that are kind of built into the system. All right. I think those are sort of the 4 projects I thought worth mentioning.
Thank you for sharing that. I mean, you've been doing this for so long, Jocelyn, that you have this experience of and to be able to share those different models is really helpful, because every single place is going to do this a little bit differently, and getting a sense of what that menu of options looks like is really important. I will say, from the perspective of a nurse care manager, it fits really well into the work that we do with OBOT when I'm seeing patients who are coming in for their buprenorphine naloxone follow-up, particularly early on and engaging in care. It is a nice way to engage people and build rapport in a slightly different way, and also facilitates quicker access to treatment if that ends up being needed. So it's been a cool way to build on the skill sets that we already had here at Harborview. Albert, I've shifted over to you. I know you've been pivotal in spearheading what's going on at PCHS, and then hear from Hannah about what that looks like sort of on the ground with care in a busy primary care clinic. How's it going, and what does your model look like?
Yeah, we're probably on the opposite end, where we're fairly new, and as I was admitting to everybody else, a work in progress. It has really been a team of champions here, Hannah being one of the major ones, as well as Dr. Proudfoot, who was unable to join us, but we have been doing, again, integrated OUD treatment for quite some time, and have always had the screening part of it down, in that we had, in our initial order sets for upwards of 8 years now, always been screening for hepatitis C. What to do with it once we do identify it has been kind of more of the recent learning curve. Prior to the pandemic, for one reason or another, I think we were both looking at competing priorities, and for better or worse, perhaps unfounded, we also thought that we were potentially stepping on our local specialists' toes, and taking some of the low-hanging fruit within their patient panels. Since the pandemic, as we all are painfully aware, I think there's enough to go around, especially with the specialists. So we actually started back in 2023, so just a year ago, really doing this in a more structured standard of practice way, whereas we had some early adopters and some true champions kind of doing it as a one-off basis. Again, our focus as a FQHC was how to make it more consistent throughout. And so I would say, again, getting into the programmatic things before I can turn it over to Hannah for the more real world clinical part. In the last year, we had, just to give you about the size of our clinic, we have 35,000 medical patients in 2023. We screened about 3,600 of those patients in the last 12 months alone. Of those, we had about 51 that were confirmed with positive RNA. Of those, about a third were managed by specialists, about a third by PCPs, and then about a third, sadly, were untreated, mostly despite multiple attempts to contact. So they were essentially lost to follow-up. Of those that were managed by PCPs, we had over half. So actually we had 12 that had completed or are in process of completing their treatment. And we had, strangely enough, like most good reports, 27 prescriptions, unique individuals that filled prescriptions at our pharmacies. So actually more than we had identified in our medical records. So anywhere from 20 to 30 patients being treated within the last year at PCHS.
Excellent.
Then I'll just
Hannah, tell us about your experience doing this work as a prescriber.
So I'm a new grad-ish now.
Hannah, your microphone's a little bit scratchy. I'm not sure if it's.
Is that any better? I'm on the old school.
Yeah, that might be a little bit better.
Okay. So I'm a relative new grad myself, been here a little over 2 years. So I don't have a lot of our program experience with or without Hep C treatment, but about a year ago now we started talking about it, and my experience was the timing was interesting because in the same time as we're talking about it, I had 4 unique patients who mostly through our MAT program, who I had identified as being positive and really wanted treatment. And most of my practice is at our Belfair office in Mason County, and there is not a GI practice in Mason County. And so Mason County Health Department has been really pushing for primary care for quite some time, even before PCHS was necessarily interested in that. And so the reality is the vast majority of the patients that we see and diagnose, we're lucky if they come back and see us for follow-up. I actually have 2 right now. I had one this morning. I thought it was ironic that no-showed her appointment to do her 3-month follow-up PCR. Dang it, it would have been another success story. But so we're lucky if they come back and see us, but the idea of going out of county to a specialist to receive Hep C treatment is just really out of the question for many of these patients due to socioeconomic status or whatever other limiting factors there are. So I think it's been really encouraging to see the response to this. Patients are really excited about it. They are encouraged by the fact that, we can lead off with, it's not like the medications that you might have heard of some years ago. It's a lot better tolerated. We can do it here in primary care. And once that's all explained, they're really passionate. They want to be treated. And so once we give them that opportunity, then it's been a really positive uptake from the patients, I guess I would say.
Thank you. I think that leads itself kind of naturally into one of the next questions I had, which is we want people to be able to access this care in the setting where they're already getting care, but some patients have more complex conditions than others. And I'll start with Jocelyn, how do you sort of make that decision around, like, what are there parameters that you have set, or how do you decide who is treated in primary care or at ETS and who should be referred to a specialist? Do you consider socioeconomic or the other kind of realities of whether somebody can actually make it, or is it really just based on certain lab values, and how do you go about that?
Yeah, good questions. And I think yes and yes, all of the above. So there are there are some guidelines around this when specialty care is indicated, and it's worth for anyone who gets interested in Hep C treatment for any prescribers, or honestly for anyone who's just trying to support people who have hepatitis C and want to get treatment and trying to figure out what might be right for them, what level of care might they need. The hepatitis C, the sort of gold standard hepatitis C treatment guideline is a joint guideline from the AASLD and the IDSA, so that basically the professional societies for hepatology, liver, and infectious disease. It's a joint guideline and it's a living guideline. And they do have some criteria there around people who should be treated by a specialist. And so just some examples of that are people who have decompensated cirrhosis, people who have liver cancer, people who have previously undergone liver transplant. So it's those are really important populations, but they're just a tiny minority of patients with hepatitis C that we'll see. And there are a couple others that can be considered. I don't personally treat people who have HIV. It's just we have an HIV clinic here, so that's not part of my practice. Similarly, if someone has comorbid hepatitis B, I would refer to liver clinic. So those are, I think, some of the key reasons that I might refer. There are people who are maybe a little bit borderline where I think it would be ideal to get specialist input, but we've seen that the patient hasn't been able to connect, and in spite of some efforts. And so I think there is sometimes a gray area where we can kind of discuss that, have the, get the input from the patient and make a decision together. And then I also have the benefit here of being able to phone a friend, or I participate in the Project Echo program that some folks here at UW lead. And so, I can like drop in there. I have ways I can get some input if needed, if the patient doesn't want to go to liver clinic. But I think even in, I can't imagine, like, it's such a different setting from being on the peninsula, and I'm surrounded by, there's a FibroScan across the street, and there are hepatologists in this building, and I still see a lot of patients who cannot get here. And we really just try to lower barriers whenever it's like medically appropriate to do that, and make sure that we're not kind of unnecessarily leaving barriers in people's paths.
Yeah, thank you. Albert and Hannah, you're in a slightly different situation. Jocelyn and I work in a place where specialty care is, like she mentioned, pretty close by physically. What does that look like for you in terms of how do you all make the decision around referring to specialty? And also, when you do, Hannah sort of alluded to this, where do people go?
Is that me or you?
Either one. I guess what I was going to start out by saying is that we have a number of really courageous providers, Hannah being one of them. And so I think having these champions, and similarly, even though we don't have, hepatology or anything like that, having a provider champion that the rest of the system can lean on is super important. I would say that in trying to do this less haphazardly, we are an organization that loves our standards of practice, and Hannah will laugh because those are always something that we kind of try to make detailed enough that they're a standalone, again, living document, and they are not unlike the simplified treatment regimens that were alluded to. And so our standard document, guiding document, is actually less than 2 pages, or less than 1 page back to front, I should say. And so who we cannot treat is actually fairly simple and lined out, in that, again, it's people that have cirrhosis, people that have received treatment in the past, people that are HIV or Hep B positive. We also had lower EGFR, so renal function, or pregnant or breastfeeding. But we try to encourage people that everybody else is pretty much fair game. And so what we are trying to do is create a system where, regardless of the provider who sees you, you have the opportunity to be offered treatment. And oftentimes those providers will go back and review the documents and resources that we have. Or, as I have recommended as recently as a month ago, hey, you should call Hannah because Hannah has dealt with this with 4 or 5 patients already. So I think it's using our internal peers.
Hannah, do you have anything you want to add to that?
No, I think that's pretty straightforward. And then I would say that there are a couple of examples that stick in my mind of people who have fallen into those categories of people that we don't treat, and some have successfully been referred to GI. Most of my patients in Belfair end up in Gig Harbor at the CHI specialist groups there, but there's probably an equal number who are lost to follow up or come back and see me in another 9 months, and we have the same conversation and we place the referral again, and it again just kind of goes nowhere. But it's mixed.
Thank you. And if people have questions and want to go ahead and raise your hands or put questions in the chat, please feel free. I'm gonna move on to one more question that I really want to make sure we get to. John mentioned this in his presentation, and you all are talking about, things that might prevent somebody from getting treated in primary care. I'd like to hear from all of you about how you sort of incorporate this into the work that you do related to prescribing medications for opioid use disorder. And sort of in Washington, one of the groups that's highest risk of developing hepatitis C are people who use drugs. And so if you could speak to the value from the patient level, as well as if you want the public health level of doing this work and offering this treatment to people who use substances. And Jocelyn, you're unmuted, so I would invite you to start.
Sorry, I was going to jump in. Thank you. I will come right back to that. But I guess I just want to highlight real quickly. I'm so glad to hear, Albert and Hannah, that you have a one-pager that's like, this is our guide. 2 things, but that alone, I think it's just even though hepatitis C treatment with direct-acting antivirals has changed, like the treatment landscape is radically different from the interferon days, but a lot of providers as well as patients may still not be fully convinced of that, might not be aware, might not be just familiar with it. And really, in the vast majority of patients, hepatitis C treatment is so straightforward and it's so likely to cure people. And even Hannah, for your patient who never came back for their SVR12, I mean, you can kind of like, if they took most of their medicine, they're probably cured. So you still did the right thing to treat them. And anyway, I love that you've like simplified it as far as so that anyone in your group can utilize that. But I feel like the messaging also is, look, this is not that hard. We can do this. And then also I think just the importance of having a couple of people get started with it, get a little experience, treat a straightforward patient. And it helps. I mean, we all have to start somewhere, and starting with the straightforward patient makes a lot of sense. And then you're already a resource for your peers. So I just wanted to highlight, because I think that's how we all have to get started and how we have to increase the uptake of treating hepatitis C in primary care and for people who use drugs. But yeah, Maureen, so turning to that question, I feel like a lot of the messaging that I've done around hepatitis C treatment is not so much the nuts and bolts, but it's more the like, why is this important? What's the rationale, et cetera. And certainly from an individual perspective, hepatitis C, we used to say SVR12 or SVR instead of cure, and we still use that term sometimes, but really we can say cure now because these medicines are so effective. So people are getting cured, and they're getting cured with, often 8 weeks, even with incomplete adherence of pills that you take every day and that are well tolerated. And so I think just spreading the word that it's so effective, and then the benefits are many, medical health, sort of more medical benefits, I guess, reducing risk of developing liver-related complications, liver cancer, death, some of the conditions the non-liver conditions that go along with hepatitis C. But there's also evidence around like positive psychosocial changes with hepatitis C cure, being able to relieve yourself of this burden that's associated with a lot of stigma in some cases that you've carried around for 30 years. For some people, and being able to get that off your shoulders can be really empowering. We did study that has some serious limitations to it, and it was a retrospective study, but we looked at patients in our OBOT program who had hepatitis C and those who'd been treated for hepatitis C, and we compared like whether they'd been treated early or late or not at all. And we did find that there was an association between treatment and likely early treatment and retention in OBOT. And I believe that as a provider, I believe that's true. We definitely need more data to really be able to say it, but I believe that speaking to that psychosocial benefit, that curing hepatitis C, engaging in that process, having somebody partner with you to help you get this important condition cured can be really motivating and kind of help energize someone's motivation for opioid use disorder treatment. So, and then there's a really strong public health argument for treating, as Maureen and John kind of laid out. A lot of hepatitis C transmission is happening in smaller groups of people, with certain risk factors, including substance use. And so if we can target the populations where transmission is occurring, we can also treat to prevent for transmission. So there's a real public health rationale. And I think it's really important to get that word out, that substance use is not something that disqualifies you from treatment. It might mean that you need additional supports, but it actually makes treatment even more important.
Thank you. Absolutely, I agree. Albert, can you share a little bit about just how you make this work in terms of your MOUD SOAR work and how that's gone and the benefits you see?
Yeah, again, I think it comes down to something we've always screened for. It is actually the same rationale that we used and why we are doing MOUD work in the first place. Is we did a great job of screening, doing efforts, and we found a lot of people that are in need of MOUD services. And so now we have an opportunity to treat that. And so taking that one step further, now that we're screening for hepatitis C, it feels good to be able to deal with the patient as a whole patient and not just segment it out and saying, I'm only here for an MOUD visit versus hepatitis visit versus, diabetes, hypertension, everything. So I really enjoy working with Hannah and the other primary care providers because they get to experience the patient as a whole. And so I think this is really just pulling in something that seemed to be very complicated. Now, again, emphasize that honestly, it is much more simple than we often give it credit for. And then to that same point, educating the patient that this is a fairly simple, straightforward regimen. We'll walk you through it. We have involved pharmacy, as it sounds like Dr. James has as well, in trying to make sure that we even have simple reminders. We work on getting community health workers involved, we've have been very fortunate. Again, I will acknowledge the immense work that our healthcare authority and John had put into being able to make the medications accessible. But even with our Medicare patients and patients with commercial plans, we have a support network that's really working and trying to make sure that patients get their medications and that we have the follow-up. So I think it's part of that wraparound care, and I think we'll try to continue to emphasize this is that wraparound care that we're all trying to get towards.
Thank you. Hannah, how about you? How do you find that this complements your work day to day with the patients that you see and the care you're providing, both in terms of Hep C and MOUD and all the other primary care needs people have?
Yeah, I think that Albert said it really well. It feels good to have a solution to a problem that you maybe identify. And I think that in integrating with our MOUD program, those patients tend to be very motivated to get treated because I think they see a potential responsibility of spreading virus, and they feel a lot of personal responsibility in that. They don't want to do that. And so I think that if a patient is really motivated enough to come and pursue MOUD, they tend to also be really diligent about doing whatever they can to get treated for Hep C. And then we can have conversations about risk management and, sharing that it's not just needles. Like if we're sharing pipes, we could also spread virus. And so I think that they tend to be very dedicated patients to this kind of treatment.
Thank you. Thanks for sharing that. I haven't seen anybody put any questions in the chat or raise their hands, but it is open for folks if you do have questions. We've got about 5 minutes left, so I do want to make sure that others get the chance if they have questions for the panel or for John from his presentation earlier. I want to give everyone the chance to share.
I guess if I could add something real
Yeah,
quickly.
please.
So I guess one of the lessons learned for us is to frankly implement plan, do, check, act, plan, do, study, act from the get-go. So we're at our first year now, we're really learning. And a lot of it has been, again, that loss to follow-up. And so really working, and I know that this is an emphasis of the guidelines on minimizing those steps. So as simple as making sure that we're ordering a antibody test that will reflex to get the RNA right away so we don't have to bring the patient back. Having those conversations early and often versus having to pull them back for yet another conversation. Even just the labs, we've tried to minimize the labs that we need for pre-treatment. And even among those labs, we as a system have agreed that we're within the last 3 months, that's close enough, and we don't have to necessarily pull new labs if we anticipate that the patient status hasn't changed. And so trying really hard to eliminate some of those barriers that are barriers both for patient but also for providers and getting going with treatment.
Gosh, that's a really good point. Thanks for sharing that. That makes a lot of sense. It's also just less burdensome, even for the patients that are showing up. It expedites things, which everybody can benefit from. Thank you. Jocelyn, do you have any lessons learned, any tidbits you think would be helpful for folks going forward?
I would definitely second that point. In fact, I was just talking to a colleague who helps direct the Evergreen Treatment Services, and I know they're rolling out more screening, and we were discussing how they're going to, with their initial screening labs, they're going to include a CBC and a CMP, basic lab, so that for people who have really uncomplicated hepatitis C, they may well have all they need, after that. So I completely agree with that. Or if you're seeing a patient for a different reason, and maybe you, for some reason, can't do their Hep C treatment, and you're referring them or whatever it is, just like trying to get things ready for the treating provider. But I guess another maybe I'm not sure it's a tip, but just some message that I would like to share is that it's one common concern about treating people who use substances is that they're going to get reinfected anyway. And so in addition, I think we've sort of indirectly talked about, people who use drugs, our rates of cure are still high. People can complete treatment, people can get cured, and it's really important to treat this population. And I appreciate someone sharing with me, a few years ago, the idea that if you have some cases of reinfection, that is a sign that you're treating this really the right population, like a really important population to treat. And so I like that idea because it just highlights that public health benefit. But I do also just want to share that for people who are accessing, I know this is a SOAR network, so for people who are wanting treatment for their substance use disorder and are accessing MOUD, rates of hepatitis C reinfection are less in that group. They're also less for people who are using syringe exchanges. And even in addition to that, I would just say that rates of reinfection are lower than rates of primary infection. So yes, reinfection happens, but it's actually pretty low. It's reduced further if people are on medications for OUD and or are using sterile equipment and supplies and everything. So
yeah, thank you. I think that's an important point to make, because it is sort of the next logical question that comes up is if we're focusing on this population, what does that mean for reinfection? And I appreciate that point that yes, you're treating the right population if reinfection does occur. Thank you all so much. It's been the hour has flown by. I really appreciate, John, your presentation on high level stuff in the state of Washington, so helpful. Albert, Hannah, and Jocelyn, thank you all for taking the time out of your days to share your experiences so that others can hopefully learn and take this on in their own settings around Washington. It's 1 o'clock, so we're gonna wrap up. I will say that next week on Wednesday, we do have a presentation with the nurse care managers. Jocelyn had mentioned that that we have the nurse care manager driven hepatitis C kind of connection to treatment model here. And the nurse who's really helped spearhead that at Harborview, Addie Adwell, who most of you are familiar with, will be presenting on that work and why it's so important. And then in addition to that, which is happening on Wednesday morning next week, we have our regular ongoing trainings and some additional new ones, including life outside treatment, which is going over this past year's syringe exchange survey, and the care navigator call and jail call and the emergency department calls are all happening as usual. So thank you everybody who could join us. Thank you to our panelists. I hope you all have a wonderful day.